tonight for migrants, because they're the ones that are affected by it at the moment. So just a bit of housekeeping. So firstly, we'll have a series of speakers speak, and then at the end, we'll have a question and answer session. I'll be giving priority to people with lived experience to ask and answer questions. Feel free to raise your hand, put a question in the chat as you think of it, or turn your microphone on when the time is appropriate. The speakers will be recorded, so if you don't want your face on camera, please turn your video off, but we won't record the question and answer session. So I think that's the introduction for now. So I'm now going to introduce Violet, who's going to read some statements written by asylum seekers about their experience with healthcare.
I think you need to unmute, Violet.
Hi, everyone. I have a few readings from people that have experienced things that happen in the NHS. I am a 30-year-old young man from the Middle East and has one kidney. They sent me to a hostel with a large number of people during the pandemic without any service or assistance. When my test in Wakefield Hospital was positive, they sent me back to the hostel again. I was lucky to survive. The second one is from a lady. I am a woman from the Middle East. I was at a hotel at the time of the pandemic. When I went to the hotel clinic and they diagnosed me with all other pandemic people, they took me to another city to a single apartment without even giving me any spray pills. When they came to check me, he promised to send me some pills, but did not receive anything for 14 days. And for the first 5 days, I had no hot water or any home appliances. I was in shock and did not know English and spent the darkest days of my life. This is also from another lady. The clinic in our hostel provides only paracetamol for everyone with any type of illness, and only one type of pill for all types of mental health. There was no doctor in this clinic, only a nurse examining and prescribing to asylum seekers. In Britain, can a nurse prescribe for a patient any tablets? I am a young girl living with my mother and my teenage brother in a house given to us by Mears in Halifax, which was full of mice. It was not possible to sleep at all due to the noise of the mice at night. The local church had twice helped us to spray and kill mice, but my little brother, who slept in the same room with my mother, could not sleep at night and was always in fear and shock of mice. My mother used to just kill and collect the mice. The doctor at the clinic described my brother's mental state as worrying. But when we asked my brother's doctor for a letter based on my brother's mental worrying history, they asked for £25 to get this letter, which we could not afford. I am an Arab woman with a son and 3 daughters from the Middle East, who has been in a hostel for a long time. My little girl is severely disabled. The clinic in our hostel did not provide any services for my little girl or for myself. I am suffering from severe mental illness. The only thing the clinic always had for us is paracetamol and sleeping tablets and nothing else. These are testimony from people that are in the asylum system.
Thank you, Violet. Really powerful. We're now going to hear from Simba, who's an asylum seeker in Sheffield. Simba suffered a stroke and was given a 6-figure bill from the NHS. And I think his story is representative of the hostile environment in the NHS. So we're now going to, Simba is here for the Q&A, but we're going to watch a pre-recorded video about his story.
Remember correctly. I came in the UK in April 2004, if I remember correctly. I started in Kent, in London actually. I lived in Kent up until I was around 1920, which is when I moved to Sheffield. That's when I then became an asylum seeker after all those years. The last few years, give or take, because it's been about the past 2 years that I've been in Sheffield. I suffered a hemorrhagic stroke after quite some time, a lengthy period of illness, and it was kind of a life-saving treatment that I actually needed to have, and I ended up having a craniectomy or something. I think I said the right word. Yeah, so they had to take a piece of my part of my skull off to release pressure because of the swelling of the brain. So during that time, that's when, that was about 2 years ago. It was last year in 2029 in June. So it's been almost 2 years now. So that can sum up my last few years in Sheffield, where I've been recovering. I'm still recovering, in recovery. And during that time, after the stroke, I got served a bill for that life-saving treatment that I got for £93,000. And due to that incident, I've then started a campaign against those NHS charges, because I was being charged like medical tourist, yet I've been in this country for half of my existence, to be honest. So we started a campaign called Justice for Simba. And I'm glad to say that we've had, I think now we've got about 66,000 signatures on a petition we launched. And this is actually gone very good. So this is just summing up the last few years of my time in Sheffield, and also an asylum seeker. Campaign has got a link on Facebook where you can go and actually just peruse through and see what it's all about, and it's linked to different organizations like SYMAAG, Maternity Action, Migrants Organize. These walls so they've all been organizations that have helped support the Justice for Simba campaign throughout the past couple of years. And so you can actually join if you want, you can join the petition and just go and sign and join a group and see how you can assist either people like me or people that, people who you know who've suffered the same kind of system injustice. Due to, because how the campaign started was initially we felt that there was serious injustices by the Home Office being used as sort of like policing immigration enforcement, where the Home Office puts pressure on the NHS, which then turns into the NHS having to police immigration and trying to figure out whether you actually a documented person or not. So this is how the Justice for Simba campaign started. First, it had a lot to do with the £93,000 charges that I got charged for my life-saving treatment. And then as time has gone on, it's just been more, it's been evolving, you know, to many different things, because it was more of a stand for equal rights and justice for many people who have seen actually it's not only me who suffered with I'm sure some people never actually got the chance to actually speak up and speak up against these injustices. So I just thought that since I have so many people behind me and knew a lot of people who could help me launch a campaign and fight against those injustices, I thought I might as well try to speak up for those people who might necessarily not have either the guts to actually go and stand up and talk, because there is a fear factor to all this. If you're an asylum seeker like me, usually most people tend to fear challenging things that involve the government. That's going to be the immigration, the NHS. You know, some people, I was one of those people at some point where I just isolated myself and never really wanted to engage with anyone. But then I noticed that, you know, as time went on, I had the support. I just had to do something about it and try to make sure that most people that don't generally get the chance to speak, I can speak on behalf of them as well, which then makes it a very stronger campaign for me, because I'm not only speaking for myself, I'm trying to speak for everyone and try to get these charges curtailed. So we then move on to another fight, whatever it's going to be. I mean, we do get involved in different types of campaigns, like, you know, reporting as an asylum seeker and all these things. So they are kind of all intertwined in many, many campaigns, you know, which I'm part of. So yeah, I mean, it's fairly simple once you tend to figure out that the more you speak up, the more people start understanding exactly what the situation is. Because not many people, even I myself, you know, did not know that there are some British-born people who actually have to go and sign, you know, and report, because they just, you know, it just mixes up with the Windrush scandal as well, where there's some people that are even born in the UK who actually never had status. And I was very shocked to hear that. And I always thought I was on my own, you know, and a lot more people who just come from outside. There's so many people even who are born in the UK who still suffer similar injustices. So I think we all need to put our heads together and try to fight against these serious injustices. Yeah. Because I mean, the hospital charges, they come in different forms. Because with me, they started, how it actually started was actually very funny. It started with me going to report the Home Office. And then when I reported, they did ask me for my, asked me if I was on any medication. So me being me, I didn't really think much into it. And I did say, yes, I was on medication. Then they told me to come back the next time I sign and bring that medication. So when I brought in that medication, they had a form ready for me there to give them consent to actually go into my medical records and find out what the situation was. And I'm not too sure why they'd want some personal stuff like that, of which I felt it was more of like a bullying tactic that they're using just because they know that I'm a vulnerable asylum seeker. Most of us just tend to say yes every time because you're afraid that if you say no, chances are it might have an impact on your case. That's how it's always made to seem like, and it does happen sometimes. So as soon as that happened, letters started coming in for prescriptions as well. I started with prescriptions before I even went for my surgery. So that's when I started getting some charges. I think the first one was about 5,000. So I don't know where that came from, but for some reason they managed to talk to the NHS finance department for them to send me some charges from those prescriptions. So that's how it started fairly earlier on before my stroke. So as time went on, I didn't really know how to deal with it during that time. And I went to Red Cross and I went through a procedure where I had to figure out whether I could, or obviously I couldn't pay for it because I'm not allowed to work, which is another kind of it's a tactic they use to kind of try to figure out what you're doing in your life. It's always a monitoring situation. So those charges, I mean, as time went on, after my initial 93,000 pound bill, Justice for Simba was mainly to try to get rid of those charges and see if we can make sure that people, if people aren't allowed to work, it's not their fault that they can't pay for their medicines. If you allow people to work, they will be able to pay for their own medicines if you want them to pay for them. So it's a no-brainer, really. So, I just see it as just sort of like a deterrent tactic that they use to try to frustrate people as much as they can. And as you can see, it's kind of work in my case, because they push you to a certain point where, at the age of 29, I suffered a stroke, because these stresses are real. And, and I mean, we know that during the time I'm actually still waking up from a coma, that's when I was going to be served with a letter for 93,000. That was the biggest shock that, I always sometimes joke around and say, with friends, say I'm surprised I didn't even have another stroke during that time. So I think the key point of Justice for Simba to fight against NHS charges and make the whole NHS sort of like a fair and just system for everyone. Okay, yeah. I mean, personally, I can't really complain about any mental health issues. There are some that I notice from day to day. And obviously, as a stroke patient, I'm prone to actually have more stress and more frustration, from being an able-bodied person to being a person who can't use my whole left side efficiently at all. So you tend to get very mentally frustrated with the day-to-day simple tasks. So that's probably what I can mention as a mental health issue that I'm probably struggling with. So I mean, during the COVID, I can't really say there was much difference in terms of how I was living, because I have been kind of in permanent lockdown for almost 11 years now. So to me, it wasn't much of a change. Only difference is I had people around me. I had my more around me than before, which kind of helped in a way, because I needed help with the day-to-day things that I can't do on my own. See, so yeah.
Thank you, Simba, if you're here. I'm not sure if you're here yet, but yeah, it doesn't need anything saying after that. I think it was pretty powerful. So we're now going to hear from Simba mentioned in his video that MedAct had been supporting him. So MedAct is a group of health professionals that want to work together to make sure that everyone has their human right to health. So firstly, we're going to hear from Dr. Sophie Williams, who's a member of MedAct, and Docs Not Cops, who campaigns against borders in the NHS and has actively worked alongside Simba in his campaign against the charges he faces. So over to you now, Sophie.
Thanks very much, Lily. Yeah, it's really great to be invited. So thank you very much. And yeah, Simba's story is so powerful. So I'm really pleased that that we started with that. So yeah, I'm Sophie and I'm a doctor in South Yorkshire, and like Lily said, so I'm a member of MedAct and Docs Not Cops, and those are organisations which campaign on access to healthcare and to scrap charging for healthcare in the NHS. So in the next 15 minutes, so I'm going to speak briefly about the framework of NHS charging, how charging happens, examples of people affected by charging in different aspects of NHS care, and the impact of charging during the pandemic. And then Anna is going to take over and talk about some of the brilliant campaigning work that's happening nationally. So just to start about the history of charging. So NHS charging is just one face of the hostile environment. And I know, during these fantastic talks, we've covered a lot of different aspects of the ways in which people are affected by the hostile environment. Restrictions to living in public life. So it denies a right to rent, to open a bank account, access legal aid, as well as, there's no recourse to public funds. So no ability to be able to access a lot of the welfare that's on offer. And then also it restricts what kinds of healthcare people can access. And it has real implications for people. It's a form of a border, on accessing welfare. But it also, like Simba mentioned, actually it implicates people who work in the public sector, and it implicates, people like health workers, teachers, to be complicit and to inform on people who are felt to be evading, some of the framework of this hostile environment. So the charging in the NHS, it exists via two different legal frameworks, and Simba touched on both of these aspects. So the first is the actual framework for charging, and so that's NHS charges for overseas visitors. And the key framework for this started in 2015. Hospitals could charge individuals retrospectively for care up until that point, but this is when it becomes really entrenched in the Immigration Act, rather than it being a subsidiary of the NHS kind of previous health bills. And so that was the implementation of the 2014 Immigration Act, and that imposed 150% retrospective charge on any secondary treatment. Now that is any hospital treatment after you've gone through A&E. So basically anything that happens as an inpatient that wasn't thought to be emergency care, that was what that applied to. And at that point, it was at hospital's discretion as to whether they shared information about patients with the Home Office, and that was both in terms of medical records and also about immigration status and any outstanding debt. So we then move on, so 2017, so again, like relatively recently, we actually see the introduction of upfront charging. So this is where people who are felt to not have an urgent and necessary condition could be assessed for their eligibility for free NHS care and be told, no, we won't treat you for this condition unless you pay upfront. And we also saw alongside that an expansion of what was chargeable. So it expanded into community care and crucially for mental health care. And so when we were hearing the testimonies right at the beginning, actually those experiences, they ring through from the fact that mental health is now ring fenced and is very difficult to access for people. And at that point, so 2017, it becomes a statutory requirement of hospitals to charge. So that means identifying chargeable people and possibly sharing information. And then 2018, that's where we see a hike in the immigration health surcharge. So it had been initially about £250, then £400, and it's now, like Lily said, £624. So for a 5-year visa, you're paying almost £3,400 with that, in addition to a visa application. That's absolutely extreme. And then the second mechanism, so that's all of the kind of charging framework. The second mechanism that the hostile environment in healthcare works is through data sharing. And again, Simba mentioned, how did the Home Office get this information? How, what piece of paper did he have to sign? What was asked of him? So in 2016, the Home Office had to kind of make requests of NHS Digital to release information about individuals. And in 2017, there was a kind of a written up memorandum of understanding, so a kind of draft legislation that basically said that information could be shared without any barriers. Now, actually, that was questioned, and a coalition of organisations kind of challenged the government, and the Health Select Committee actually put a temporary ban to this. So at the moment, data sharing, that automatic data sharing, has been stopped. It only exists in certain particular circumstances where somebody is felt to have committed a serious crime. Now, it's really difficult to know exactly what that means, but that automatic transfer of information has stopped. However, the request of information, so like Simba experienced, where GPs are asked by the Home Office to consent to share information, that can still happen. So next, how does charging actually happen? So basically, whether people are deemed chargeable or not for care is based on the concept of ordinary residence. And this means that somebody would have leave to remain, and you can show, and that person would be able to show that they live in this country habitually. People are identified for charging in really inconsistent ways. Sometimes that's by reception staff or healthcare workers themselves. Sometimes that's overseas visitor managers identify people through a combination of NHS records and some algorithms about how recently people have kind of been given their NHS number. And then sometimes people are asked to bring ID to their appointments. So that's been an issue for outpatient appointments, for instance. And upfront charges, they apply for all care that is not urgent or immediately necessary, and this covers most outpatient care and some GP services. And otherwise, that care is now billed retrospectively. So like Simba had with that £93,000 kind of as he'd just woken up in ITU. If you've been identified as chargeable, so some people and some conditions are exempt. So for instance, asylum kind of claimants are exempt, and people who've experienced trafficking and domestic slavery are also exempt. But because there is a confusion about which treatments are free, who should be charged, basically it means that everyone is under suspicion. And then there are some things that even if you pay the surcharge, you're still not eligible for treatment. And that includes things like assisted contraception. So we've heard a lot about, so Simba's case here in Sheffield. There have been a number of other cases nationally. So Sylvester Marshall, he was his case was in the press back in 2018, where he was denied treatment for prostate cancer. He was one of the Windrush generation who just couldn't prove his eligibility for treatment. It took 6 months for him to get treatment, and then he finally did get treatment, but it was a real haul for him, no apology. The Victoria Derbyshire programme had a real expose on different cases of the ways in which people were affected by charging. This included a young mother whose baby tragically died after an emergency C-section, and she wasn't able to take the baby home until she paid £10,000. There are a whole number of others. Elfrida Spencer, a woman who died after she was denied chemotherapy. Nazir Khan was denied a heart transplant. There are so many key cases where different aspects of healthcare have been denied people, and it prevents dignity. It stops people from living a decent life and having the dignity and being treated with respect. So these cases that I've just spoke about are all kind of pre-COVID. And while COVID itself is listed as an exemption, so COVID care in hospital should be free, the charging has still resulted in unnecessary harm and tragically even death. And the 2020 MedAct report showed that people were not coming forward for healthcare because of the government's hostile environment, and specifically naming that data sharing, that the coronavirus exemption wasn't working, people didn't know about it, and that all of the other additional barriers, trusting health workers, language barriers, mobility when people's money is really limited, especially if they're limiting, they're not able to work because of their immigration status. And so all of those things have been kind of barriers to people accessing healthcare. And kind of recently with vaccination, so the vaccination programme is being run through GP registration, and there's been a big drive through the government. Yes, everyone go and get your vaccines, and it is really important that people are vaccinated. But there hasn't been that amnesty in the data sharing. And that's, I know that Anna will come on to talk about this, but that's where a lot of the campaign work is around. And we have to be really clear that, at the moment we're failing to vaccinate huge communities. The BAME community vaccination uptake is only 66%, with white communities it's 92%, and that's a huge failure, and we need to work more on that. And I haven't found any good data on people who are non-ordinarily resident and who would otherwise be chargeable coming forward for vaccines. So I don't know if anyone in the Q&A afterwards has any experience of that, or has any good data that they've read, or any good papers. I'd be really interested to hear about it. So thank you for that whistle-stop tour of all the charging. And Anna's now going to talk through the campaign work that's going to change all of this.
Thanks, Sophie. Hi, everyone. I'm Anna. I'm also a doctor working in South Yorkshire, and I'm a member of Docs Not Cops and Sheffield MedAct. So yeah, as Sophie says, there's been a lot of kind of national campaigning work since these charges have been kind of introduced and expanded, both by healthcare workers who, we see the negative impacts of these policies on our patients, and they completely go against all of our kind of feeling of our responsibilities to our patients to have these borders in the NHS, and also kind of campaigns from migrants' rights organisations, I guess like SYMAAG and lots of other groups. I'm just going to talk briefly. I'll definitely miss out lots of amazing campaign work that's going on, so this is not exhaustive. But so the Patients Not Passports Network is a group of groups in lots of different cities all over the UK, which is a mix of kind of Docs Not Cops and MedAct groups. So Docs Not Cops is a kind of grassroots campaign of healthcare workers set up to oppose this introduction of the hostile environment in healthcare. And MedAct, as Lily talked about, and Simba as well, is a kind of national campaigning organisation of healthcare workers. And there's also a kind of access to healthcare strand of organising from Migrants Organise. In some areas, these are kind of connected to Save Our NHS and Keep Our NHS public campaigns. Like Lily said, that this has kind of implications for the healthcare system overall. And some of those groups, particularly in London, have done really great work pressuring local hospital trusts with freedom of information requests and questions to hospital boards about charging. And so groups have done things like direct action campaigns outside hospitals to raise awareness of charging, vigils marking the anniversaries of introduction of charging, and to kind of mark some of the, and remember some of those people that Sophie was talking about who've really sadly come to harm as a result of charging policies. Some of the campaigning work has also been in producing advocacy guides, so both for healthcare workers and also for community members to advocate for people if they are facing charging. And that's, I guess, to do with raising awareness of what kind of immigration statuses and particular conditions and those kind of things are exempt. To be clear, I think we as like campaigners feel that the only reasonable response is to end all charging. But I think we have to also be able to advocate for individuals within the current system. And Docs Not Cops, MedAct, Migrants Organise, and also Doctors of the World are always happy to kind of signpost and support individuals with cases. And some of that casework, as like Simba was talking about, he's got this incredible kind of direct action casework campaign organising around his particular situation, and raising awareness, as he says, for people that are maybe less able to speak up. And so yeah, we do kind of like awareness raising with healthcare workers so that they're aware of the situation, because I think there's actually a real lack of awareness of how this is affecting some of their patients. And also some groups like Doctors of the World do work around helping people to register with GP practices, asking GP practices to join up to their Safer Surgeries campaign. So that's to basically everybody should be able to register with a GP. And so making sure that GP surgeries aren't putting in place barriers that shouldn't be there. Like you shouldn't have to show ID or proof of address or immigration status to be able to register for primary healthcare. There's also kind of campaign work that's more in the form of research, so kind of gathering data about the harms of charging so that then we can like push for an end to these policies. And also kind of support from trade unions and organisations like Royal Colleges that represent various groups of doctors and other healthcare workers. And so like the BMA and Unison, which are quite big healthcare unions, their policy is that they oppose charging and that we should scrap charging in the NHS. Just to briefly touch on, I guess, campaign successes. So Sophie talked about kind of the impact that campaigning had on amending the memorandum of understanding. So to try and reduce the amount of data sharing that was going on. But as she said, unfortunately, it's not gone completely, but I guess that does show that that pressure does work. The other thing that you might have seen in the press in the last year or so was that during the COVID pandemic, there was a real kind of outcry and a lot of media attention about healthcare workers and care workers having to pay the immigration health surcharge. And that actually did result in a government U-turn and it being scrapped for those groups of people. But around that time, people from Docs Not Cops were trying to also get into the press and make the case that we don't really believe in this distinction between some groups of workers are sort of more deserving of healthcare than others. Some groups shouldn't have to pay, whereas other groups do. And so kind of always trying to like push that to say, we don't need different exemptions or more exemptions. We just need the end of charging, full stop. And most recently, so Sheffield MedAct have been working a bit on this, on the Vaccines for All campaign, which is, that everybody, the government did come out and say actually before the campaign launched that everyone should be able to access the vaccine. But as we know, there are lots of kind of barriers and fear around accessing healthcare. And so the campaign's calling, as Sophie said, for like a firewall so that there's not any data sharing and an end to charging overall. And that's had lots of really like high profile sign-ups from Royal College of Midwives, Royal College of Emergency Medicine, quite a lot of city councils and those kind of things. Yeah, so I'll end there, but thank you for inviting us to talk and happy to answer questions later.
Thank you, Anna. That was really interesting, and it's always nice to hear about successes. We're now going to move on to Dr. Rayah Feldman. Dr. Feldman is a trustee at Hackney Migrant Centre, and she's currently focusing on expanding the vaccine rollout to those who are not currently in contact with the NHS. And she's also been a senior researcher at Maternity Action in the past, so she's going to touch a bit on the experience of migrant and asylum seeking women accessing healthcare. So over to you.
Thank you. Can everybody hear me? Great. Actually, I'm going to do it the other way round. I'm going to talk mainly about charging for maternity care and link that to issues about the vaccine rollout. And I just, thank you very much. I also want to say that I'm not a doctor, because that in this context, that's quite important. I've been asked to speak about the impact of charging for maternity care, having researched and campaigned on this issue with Maternity Action and other groups for several years. And I just want to make clear that I'm also opposed to all charging, but there are it is possible to, I think it's an interesting issue about campaigning for particular individuals or campaigning on particular issues. But the other thing is that maternity care is a very interesting case example, because apart from exempted conditions where if you have, say, TB or various infectious diseases, or particularly COVID now, and there are also some circumstances, maternity care isn't exempt at all from charging, but it is exempt from upfront charging, as though if you're going to be faced with a bill of £7,000 after you've had your baby, it makes you more comfortable about having it than if you had to pay beforehand. And so in a way, it's probably seen by the government, which responded to pressure about this as a kind of soft thing. Oh, well, we'll not make women pay for maternity care in order to get it. But actually, charging for maternity care has exactly the same effect as it does for other things. So I'm going to talk, I'll skip bits that have already been covered. I was going to talk a little bit again about the charging rules that Sophie talked about, but very briefly. And then I'm going to talk about work that we and other people have done. We did work at Maternity Action, and there's also been work with the Equality and Human Rights Commission about the impact of charging on pregnant women and new mothers. And then I'll also say a little bit at the end about how we should campaign on the, how we can campaign on these issues. So just to kind of review that the people who need to pay is really any migrant who doesn't have indefinite leave to remain or who isn't a British citizen, who hasn't paid the surcharge. Because actually, in order to get leave now for a period, usually of 2.5 years in renewals, you have to have paid, as Sophie said, you've got to pay for the surcharge first. So mainly that means 3 groups. One is migrants who we call undocumented, the migrants who don't have papers enabling them to live here legally. And that includes asylum seekers, people who've applied for asylum and been refused, but aren't supported by the Home Office. And it's actually quite hard as a refused asylum seeker to get support from the Home Office. You have to meet certain conditions. So in fact, as far as maternity care is concerned, there's lots of women who've been refused asylum, who've carried on living here because there are lots of reasons, as you all know, for not returning to your home country just because you've been refused asylum. And but who aren't supported by the Home Office, and so they are chargeable. People who come into the country on visitor visas, usually for 6 months, or even renewably, you can get a visitor visa for 2 years in 6-month blocks. They are not entitled. Sorry about this, it's just a tickle, but it's. But people on visitor visas are not entitled to pay for the surcharge. So even unless you've got insurance, but actually women come in for all sorts of reasons. I mean, men and women, but particularly women, because they often come to this country as the dependent of men who have preceded them and who are settled here. And in fact, anybody in your family who doesn't have leave, whether or not you, the income earner in the family is a British citizen, has to either pay the NHS surcharge if they have leave or are undocumented. And also there are British citizens who live abroad who technically have to pay for NHS care, but it's much easier for them to avoid it. And I'm not going to talk about them, but we should remember that it's these 3 groups now. Charging works, as Sophie said, it's largely payment in advance, which means that if you can't pay, you may get your treatment refused unless it's urgent or immediately necessary. Now, immediately necessary care should be a decision by the clinician. And sometimes I personally am completely baffled as to how care can be designated not immediately necessary when somebody is in the hospital, often having come through A&E. But that's how it works. If somebody can't give clear evidence of their eligibility or their lack of eligibility for free NHS care, that's when data sharing is now permitted right at the beginning of their experience with a hospital. And I'm really only talking about hospital care, well, mainly in relation to maternity care. A third thing, so like you come into the hospital and there, if you're an undocumented migrant or a visitor, there's immediately likelihood that your data will be shared with the Home Office. And thirdly, this appalling amount of money, which of course in Simba's case is unbelievable, but we at Hackney Migrant Centre had a case where somebody had cancer and had a bill for £97,000. So it's not, I mean, it is unusual, but it's not that rare. But the payment is organized, is charged at 1.5 times the normal cost. Now, the normal cost is met by the state. I won't go into that, how that happens, but it's a punitive charge because these individual migrants have to pay half as much again as what the hospital gets paid for doing exactly the same work for most people. And finally, if you have a debt of over £500 for more than 2 months, the hospital is supposed to and should report you to the Home Office. And that goes on your file so that if you do try to regularize your status for whatever reason, that can be held against you and can be a sanction that stops you actually getting your leave or restricts your leave to something less good than you might have done. So the whole thing is built around data sharing and reporting to the Home Office. Now, how it works for maternity care, all maternity care, that's antenatal care, delivery and up to the postnatal check, is supposed to be immediately necessary. So women don't have to pay in advance, but they are going to be billed, and they're often billed straight as soon as they arrive. And I think they often need to explain why they can't pay in advance. And of course, that means that the cost of the normal birth, because given the the way that charging works in the NHS, the normal birth would cost approximately £4,500. That's without complications, without a cesarean. But women who are being charged for the full antenatal package would have to pay migrant women would have to pay about £7,000. Now, what I really want to look at is who are the people who are most affected by having to pay for maternity care, and that's undocumented migrant women and sometimes visitors. Now, those women are often destitute because of domestic violence or relationship breakdown. They've often, as I said, they're often refused asylum seekers who can't return to their countries. In some cases, especially because they've had a baby, and their families, they feel they couldn't be reaccepted even if they wanted to return. Many have children from relationships that they made in the UK. Some of the people with whom they had the relationships may be British citizens, but actually that doesn't confer any right to them. And women are pregnant who have entitlements that they don't even know they might have, like they might be able to claim asylum because of the reasons that they're here in the first place. They might be able to get recognition as a trafficked person, but they don't know that. And it's really difficult to get advice. The hospital doesn't give you advice unless you're in contact with a good organization or you have a good lawyer, and the lawyers don't actually know very much about payments for healthcare. So the whole patterns of global gender inequality also mean that women are often dependent on men for their immigration status. And if so they come in and as a visitor, and then they're in a relationship, and then if the relationship breaks down, they might be at high risk of destitution because there's no way that they can get their status as the spouse of the person they came to join. And in our research in Maternity Action, we had a case like that where a woman came to an arranged marriage that she'd agreed to, and her husband was violent and she left him. She did have a relationship with somebody else, and who also left her when she became pregnant. and she was afraid to go back to her country because she'd run away from her husband. And she was also worried that her family would force her daughter to have FGM. And she applied for asylum just before she was due to give birth. But the whole period of the pregnancy, she was undocumented and chargeable. And her story shows how a woman's undocumented status can stem from her dependence on a partner and how she's treated by him. If this woman's partner had been British or had had settled status, and if he hadn't been abusive to her, she might have got leave on the basis of her marriage, but she didn't. And that's awful. And it puts women, of course, in a very, very vulnerable position, particularly. Some destitute women only survive through being in a relationship with someone, even if that person turns out to be violent or controlling. And destitute women are obviously also susceptible to unscrupulous men and who might abandon them if they get pregnant. So I just want to talk briefly about what's the impact of charging on women seeking maternity care. And the link of charging both the money that needs to be paid and also obviously the link of charging to the Home Office have numerous adverse effects. The first one is that women are deterred from seeking care. So here you've got this care, which is not payable in advance because it's so important. It's recognized in government documents about health. We're exempting maternity care from upfront charging because of the risk of complications and so on. And yet, you're at risk of everything else. And as a result, women are deterred from care. They sometimes don't book at all. Booking in maternity care is when that you enroll, if you like, in the program with a midwife. And the NHS constantly emphasizes the importance of early booking to identify underlying conditions and to monitor the course of the pregnancy so that it doesn't go wrong. We already know that Black women have a 5 times higher risk of mortality in maternity. Now that doesn't mean, you know, the risk in general, although Britain doesn't do very well on maternal mortality, it's still very low numbers. So when you say 5 times, it doesn't mean loads of people are going to die in maternity care, but but of those who do, a disproportionate number are Black women. And for the first time in 2019, a kind of statutory report that comes out regularly about maternal mortality suggested that this might have been because of women being deterred from maternity care. And late booking is very highly associated with poor pregnancy outcomes. Now, there's lots of barriers to care anyway, as we know. There's a problem for asylum seekers who get dispersed, which we also did work around in Maternity Action. Some people have talked already about the problem, some barriers to accessing GPs, and most women access maternity care through their GPs. Migrants don't know very well how the NHS system works. Sometimes, very often, receptionists at GPs are quite hostile, but there's other barriers to care. That the hostile environment itself makes migrants fearful of accessing government run services, which the NHS is. Language is a barrier, economic precariousness is a barrier, because the more precarious your economic and social situation is, the more you move around, the less settled you are, the less you have a social network that tells you what to do. And so, and of course there's racism. And so all these barriers just make it more difficult for migrant women, particularly undocumented ones, to access maternity care. But the charging is like the icing on the cake. What then happens to women as a result of all this is that they suffer extraordinary anxiety and stress, and that impacts on their own mental health. It impacts on the way that they can deal with their children and their whole families. And there's lots of evidence that stress actually affects fetal and child development. And a review that I've seen of the long-term impact of postnatal depression found that the impact was more severe, where they said, this is a quote, "The depressive episode is severe and prolonged, and where it occurs in the context of personal and social adversity." Well, you know, I quote that because that describes the situation of people without immigration status facing huge bills, without proper places to live, often having difficult relationships. I think
Rayah, I'm just going to give you 30 seconds to wrap up, if that's okay, so we have time for Q&A.
Finally, I want to say something about, I mean, I've talked about some detail about how maternity care impacts adversely on people. And I think it's really important to understand how it also, how it shows that it's not difficult to understand how the hostile environment impacts on COVID and vaccine hesitancy for exactly the same reasons that people stay away, because they don't trust these institutions. And I'm going to be very cheeky and take 1 more minute, 60 seconds, just to talk about what we might be able to do. One is that we can, as individuals and organisations, advocate for individuals who are being charged, contact the hospitals, tell them that the woman can't, or the person can't pay, that they should cancel the charges. That can be done. Learn more about charging for maternity care. And Otto promised to put in the chat, I don't know whether he did, some things from Maternity Action and a link to Maternity Action, which tells you a lot about maternity care specifically. And then obviously campaign at local hospitals with migrant campaign groups together with NHS campaign groups, because I will say Keep Our NHS Public is now campaigning on this issue. And finally, campaign for all charges to be scrapped. That's it. Thank you. Sorry, I overran.
Thank you, Rayah. That last minute was great, so thanks for doing that. I'm now going to open up the floor to questions, so feel free to put them in the chat, put your hands up or unmute. So I don't know if people know how to use a hands up feature, that would be my preference, but I've got everyone here now. I think we're going to stop recording now.